Good afternoon, everyone. My name is Jill Hansen. I'm with Superior Health Quality Alliance, and I wanted to welcome you to the state-based immunization registry's role in vaccinations. On the call today is Toni Kettner. She is also another quality improvement advisor with Superior Health. She is going to be monitoring our chat, and as you can see, she's put in the presentation slides from today's session. So our objectives for this webinar really are to provide you with sort of a lay of the land for our state immunization registries. We also want to really kind of stress that importance of that relationship between kind of sharing the data between the electronic health record and the immunization registry. And we're going to follow up with sort of what forecasting capabilities are actually available within the immunization registry. And lastly, we're going to allow you to learn a little bit more about future registry enhancements. So I am very happy that we are being joined today by two panel participants. We have Tina Scott with the Michigan Care Improvement Registry. Tina is the section manager for the Michigan Department of Health and Human Services. She oversees the registry for the Division of Immunization. And from the Wisconsin Immunization Registry, we have Matt Burden, and Matt's role at the Immunization Registry is unit supervisor. So before we go ahead and get started, we have a couple of slides that we'll kind of walk through and sort of how this is going to work is I'll bring up a slide and our panelists will kind of speak to each of those slides. When we finish the series of slides, we will open the discussion up for a question and answer. So if at any time during this session you think of a question, feel free to write that into the chat, and Toni will be sure to monitor that when we open it up to the Q&A session. If you haven't done so already, I would encourage you to put your phone or your computer on mute just to kind of lessen the background noise that we have. So with that, we'll go ahead and get started. So, so Matt and Tina, I think the first thing we want to do is sort of, as I mentioned, sort of share sort of that landscape related to the immunization registry. So if you both want to just kind of talk about really high level, I know we only have an hour, but really sort of tell us a little bit more from your state's perspective. You know, what does that look like? What does the registry look like? Is there a certain provider type that you're seeing that's utilizing that more than the other? Kind of what systems are set up to sort of use that? Also, if you have, you know, specific, you know, age groups or vaccine specific that are mandated versus voluntary, are you seeing any sort of shifts within that? And then really kind of the last thing is really around sort of that data submission via the data exchange. So we'll go ahead and I think, Tina, you are up first for this question.
Well, thank you so much for having us today. I'm glad to be here to represent the Michigan Care Improvement Registry or our immunization registry. Our registry was created in 1998 to collect childhood immunization information. But that changed to a lifespan registry in 2006. So we have a fairly mature immunization registry. It was mandated back in 1998 that all childhood immunizations be reported to the registry. So we have a very robust number of medical practices that are registered in our system. We, at this time, with regard to pediatric, adolescent, family practice, and other health practices, we have over 7,400 registered users of the system. We have 1,600 pharmacies that are registered users. We also have employee health, corrections, colleges and universities, tribal organizations, migrant health organizations. We also have a school module that exists in parallel with our registry and that our school and daycares use in order to do mandated state reporting for immunization for school and child care children who receive daycare. And so we have 7,900 registered schools and child cares that are attached to the school module on our registry. As I said, all vaccinations for those under the age of 18 years is mandated reporting and has been mandated reporting since 1998. And just recently, all COVID vaccinations are mandated to be reported to our registry. Of the 7,400 medical practices that are registered users of our system, we do have a significant number of those sites that are read-only or query-only sites. In other words, they're not vaccinators, but they desire to see the information on their patients in our system. So that means that about 70% of that 7,400 are vaccinating providers. And in the last quarter, 64% reported vaccinations through HL7 technology. 35% were direct data entry on our website. And we have 1%, a very small percent, that still do data uploads to our registry. The percentage of data submitted via a data exchange, HL7 has existed in Michigan since 2012. Of the 3,300 providers that report via HL7, this represents 85% of the vaccinations that are submitted to our registry. So we're very proud of that fact. Back in 2012, when HL7 was introduced, one of the conditions of onboarding for immunizing providers is that health information exchanges needed to provide this as a free connective service. And so we point back to that early state classification that it must be done for free, that you connect immunizing providers to health information exchange. And so we point back to that as to why over 85% of the vaccinations reported to our registry are done via HL7. Matt, I'll turn it over to you for Wisconsin.
All right, thank you, Tina. And again, thank you for having us on here. Really appreciate it. Wisconsin's Immunization Registry came online in 2000, so Michigan beat us by a couple of years. But like Michigan, we are a mature registry. We did start off with mainly pediatric providers, but we have been birth to death registry from the start, and have over the years seen significant increases with adult providers getting access to the immunization registry. The main provider types of the registry have been local health departments, pediatric and adult providers, pharmacies, long-term care, employee health. We do have a large number of schools and universities, FQHCs, tribes, and a number of other entities. We also have many state and federal partners with Medicaid-led Department of Children and Families, our disease surveillance system, and CDC refugee health. We have about 4,300 organizations that are that access WER. That does not include all of our school sites, which are around 2,000 or a little over 2,000. We do not have a mandate in Wisconsin. Statewide, we do have mandates for pharmacists that provide Medicaid services and providers that receive vaccine, free vaccine through the Vaccine for Children program. In both instances, they do have to require that information, and we do have requirements as far as timeliness of that information coming in. But otherwise not required of our providers. The other thing to note is we do not provide lookup access only. Outside of some rare instances, which is how we've encouraged the use of our registry, since it is not required. If individuals want to receive information, they have to also participate and give us information. As far as the percentage of providers entering data in the registry, we estimate it's about 95%. It's difficult to get an exact number of immunizers in our state, but through efforts, mainly looking at vaccines for children providers before they were required and other entities before they were required, we were able to determine about 95% of the data, or 95% of the providers in the state use the registry. our main gaps are going to be with our long-term care, nursing homes, employee health, and Veterans Affairs. As far as the percentage of data submitted via data exchange, about 87, looking at last year, 87% of the data we received came in via data exchange. But we had been over 90% prior to that. Some of the decrease is actually due to the tools we have within our registry for mass vaccination entry. And we saw a greater increase with those with COVID vaccinations. And I think that is all I have. So I guess I'll turn it over for the next slide.
All right, great. Thanks, Matt and Tina. So now sort of, we both talked about it. So both of you sort of, Tina, you mentioned you had 85% submitted via kind of that exchange. Matt, you mentioned sort of 87%. So again, you may have sort of talked about this, alluded to a little bit, but can you kind of speak to, is there an organization type more than the other that you're seeing sort of utilizing that component? And really sort of, if you can also speak to sort of that importance of why you want to make sure that that exchange between those two systems is that accuracy, and then reporting into that and sort of sharing of that data back and forth. And if there are any areas that you see as sort of opportunities, especially, that we've seen over in the last, couple of years. And so I think we start again with Tina on this one.
Thank you. The vast majority of users are vaccinators. The medical practices, the pediatric, adolescent, and family practice providers, hospitals and healthcare systems, and our Medicaid health plans, as well as our public health organizations, such as our local health departments and federally qualified healthcare centers. I would say, just as a trend, pharmacies have grown over the last 10 years in their presence with regard to being a submitter on the registry. They provide the vast majority of adult immunizations here in the state over general practice providers. And so they have had an ever increasing percentage representation of the vaccinations reported by HL7. They also have the benefit of being part of larger corporate organizations. And so when the large corporate organization, the Rite Aid, the Costco's, the CVS, the Walgreens, when the corporation gets things hooked up for HL7 transmission, they basically represent all their sites in the state and in connecting and submitting data to the registry. So the pharmacy data has been greatly beneficial with regard to adult vaccinations here in Michigan, because adult vaccination reporting is not mandated. So we welcome any organization that wants to report via HL7, because they generally report everything that they do and don't separate out just the mandated childhood vaccinations from the adult vaccinations. So that's a benefit of HL7, is that we get all the vaccinations for that organization, because it would cost them more money to program out just reporting the mandated vaccinations here in the state. Areas of opportunity. We have 17 healthcare systems that have 1,500 sites that on our registry are query only, meaning that their EHR will check on a patient's immunization history and receive forecast information back from our registry. These are mainly specialists who are interested in understanding if their patient who has a chronic condition has received their pneumo shot or their influenza shot for that season. And so we would like to expand the number of specialists who have this query-only capability, because they can then write the order for that provider to, or for that patient then to receive an immunization. We would also like to increase our data links to our state labs and disease surveillance system, especially with COVID. There was a great debate on whether someone who has a confirmed diagnosis of COVID would then need to be immunized. That was early on before the vaccine was available. And so if we had that ability to be more dynamically connected with our labs and disease surveillance system with regard to how lab test results, positive results, would impact a vaccination forecast, that would be an improvement with regard to interoperability. We also have a lot of information on the pediatric and adolescent data that exists here in the state. Matt alluded to it: blood lead test results, newborn screening information, and so forth. And so to be able to create a message that then can be digested by EHRs to provide all the additional state level information concerning especially the pediatric patient would be, we think, an advancement and an assist to the pediatric provider population. Since one of the disadvantages of being on HL7 is we find fewer and fewer providers are actually logging into our web application, where all these other additional data sets that are linked to that patient are contained. Another advantage of interoperability is we're expanding, or actually creating right now for the first time, our ability to have consumer access, where I as a consumer could use this portal in order to obtain a copy of my immunization record. Once that consumer access portal exists, a lot of other services can be provided through that, such as the patient's ability to update their phone number and addresses in our system, as well as to request text messaging reminding through that portal as well. Matt, to you.
I'll start off with echoing what Tina said about the large providers and the benefit that we've seen with providers going to data exchange. When you have those large systems, they get linked and they bring on all of them, or all their providers, which has been extremely useful in increasing the number of data exchange providers. At this point, we do have a large portion of our providers that use data exchange in our state. I think that the organization types that we are still working to get moved over to data exchange and increase that would be in our long-term care facilities and nursing homes, our local health departments, mass immunizers, and employee health. Though we have seen a lot of our local health departments now moving to obtain electronic health records and are linking to us. So that group tends to be moving more towards data exchange, but it does tend to increase accuracy and speed of information getting into our registry when they do use data exchange. Areas of opportunity to improve interoperability. One of the things that we've seen recently, we did see this with influenza, but more so with COVID, is the providers that want to receive information into their systems that do not want to do that through the regular query process, where an individual comes into the clinic, they send us a message, and we send back the single message with that individual's immunization history and recommendations. A lot of the organizations have individuals that we saw with COVID that were not getting regular immunization services from them, and they wanted to be able to reach out to them. So working with providers to find the means to get them that information, or even one of the things we're looking forward to possibly in the future is the ability to push out immunizations. So as we get something in, we have associations of the providers to their clients or their patients, and we could use that information to send a single message out to that provider to update their record, versus them having to send a record to us or send a query to us to get that information. Other areas for improvement in interoperability is improved exchange between states. Michigan and Wisconsin do exchange information, as does Wisconsin and Minnesota. But there are other states that we we'd like to set up linkages with, and there's some efforts nationally to do that. And one of the things that may be a possibility down the road is the ability for providers to query another state through the Wisconsin Immunization Registry. The other thing, as Tina alluded to, as providers moved to data exchange, they stopped using the user interface, or they weren't using the user interface as much, but has a number of reporting options that data exchange providers could still utilize that would help them effectively identify individuals needing vaccine, get current coverage rates of their population, and also help with inventory reconciliation. All right, that's all I had. Next slide.
Perfect. Thank you both. So again, with sort of anything that we sort of work to create, as you sort of did that initial build, and both of you were sort of, what was it, late 90s, early 2000s, kind of, designing that for sustainability. So, sort of thinking about, that initial, when we think about sort of what it took for someone on the outside, if I was a provider and I wanted to begin to enter information or have information shared into that registry, can you kind of speak to sort of the barriers around, do you anticipate maybe that might be some of the reason why I know you kind of had mentioned sort of the long-term care, the nursing homes, the health departments, there were sort of like a little pockets that you're seeing sort of as having a little more, not quite as robust system in terms of that exchange. And would you kind of both kind of speak to that? I also know that sort of, especially in this last year with COVID, I think we're seeing more with sort of that burnout. And so kind of as I mentioned, so designing that system for sustainability. So kind of some of the things that sort of those safeguards that you've got put in place, and then sort of the things around sort of how and I think you both sort of touched on it a little bit about kind of identifying opportunities for increasing the number of providers putting that information in. So again, we'll start with Tina on this one.
Well, initially, as I stated, one of the mandates here in the state was that all immunization reporting via health information exchange was to be done for free to the providers. And that was because that recommendation was made by our Health Information Technology Commission because they thought that would get the most number of providers connected early on in the development of health information exchange. And so early on we had, because it was technically for free, even though there was some technology cost at the provider end, at both our ends actually, the actual connection to transmit the message there was no cost to that. We were able to onboard a lot of almost the vast majority of our large providers and the majority of our medium-sized practices fairly quickly over these last 8 years. So the heavy lift is really with our smaller independent organizations. There's still a cost involved with regard to making sure your vendor EHR system is able to transmit messages, as well as the cost to connecting and being able to transmit that information. And so we're finding the vast majority of our sites that are still doing direct data entry onto our registry are the very small practices that need to plan that cost well in advance, as well as to prepare what the annual cost is for that to connect. With regard to staffing, yes, there was a lot of education that had to be done with the staff in order to get the staff comfortable with how the information was entered into their EHR, and being comfortable that it would then show up in the immunization registry because of the web application interface. They could often, when I visited sites when they were first getting connected, they would have the web application up on one computer when when they would tap their EHR to send in that immunization registry or that vaccination. And they would quickly look at the registry because they didn't believe us that it would take literally hundredths of a second for that information to land in the registry. And so for us to demonstrate that early on was amazing to them, how quickly that information could get in. Probably one of the more technical issues was making sure the EHR systems were programmed as to when they sent in the immunization. Oftentimes when a provider practices preparing for their patients for the day or the day before, they'll look up information with regard to their vaccination statuses, and we would get more EHR messages than we needed to. And so we had to work with the vendors in order to refine exactly when in the process of the vaccination and recording the vaccination that we received that information into the registry, so that we didn't get 15 messages every time they looked at immunization information in their EHR. There is high turnover in the provider offices. That just seems to be a fact and has been going on for many, many years. COVID has exacerbated that. A lot of us, even on our side, are burnt out from the intensity of the last 9 months. But one of the things that we did prior to COVID in preparation for COVID is began producing video-based trainings of the basics of how to use our registry. And that helped greatly with the, we had over 1,000 sites, new sites that were added to the registry for COVID reporting specifically. And so having video-based trainings allowed them to learn at their own pace and learn and in small snippets. We try to keep them under 10 minutes for each basic lesson so that we're not asking them to commit an hour-long video training. It's snippets and it's specific to what they potentially need to learn that day. And so in the future, we're going to be expanding on those tutorial modules that will be available. From the IIS registry staff, we are experiencing the same stress that the provider offices are experiencing with regard to turnover. Ours is more connected, in addition to the COVID stress, it's more connected to baby boomer retirements. We have a lot of staff who've worked for our registry for many, many years. We've been experiencing that as the stresses of COVID have just pushed more and more people into retirement. And so we're finding new opportunities with regard to bringing on new talent in order to improve our systems. And I'll talk about improvements later. But we're experiencing our own stresses with regard to burnout from COVID, as well as from baby boomers retiring. Not all, just as Matt has said, not all entities participate in the registry. We too would like more long-term care facilities or adult-oriented facilities to be reporting. A lot of times with the long-term care facilities, it has to do with the fact that in those facilities, their EHRs are different than the type of EHR that exists in hospitals or in the doctor's offices. And so there was a technology hurdle that had to be overcome there, depending on the vendor that is used by the long-term care facilities. We would also like more OBGYNs to be participating in our registry and have in the past done OBGYN outreaches in order to ensure that pregnant women are receiving the vaccinations during pregnancy. That would be helpful not only to the mother, but to the child as well. And as Matt already said, we would love to have our federal partners that do vaccinations, the VA and the military, be connected and submitting those immunizations to our registry. We're hopeful. The VA is in the process of implementing a new Cerner EHR system across all their facilities. And the Cerner system already knows how to send an HL7 message. So we're hopeful that especially with the COVID experience, everybody is wanting to make sure that they understand the COVID vaccination status of the person, no matter where they received their vaccination. And so we're hopeful that this pandemic experience will help the VA and military organizations along with getting connected and submitting vaccinations to the registries. Matt, to you.
Yeah, I guess I'll start off echoing what Tina said about it's one of the main barriers we're seeing with some of the small entities is the cost for implementing a new system as well as supporting the new system. I think another thing that can be difficult is depending on the electronic health record system that is implemented, it can take a lot longer to go through the setup and get things in place versus electronic health record that has experience working with Wisconsin's Immunization Registry or another immunization registry. That initial setup can be daunting. There's testing that needs to be done to assure that data quality is maintained in the data that's coming over. And one of the things that I guess to go into as far as ongoing support that we've encouraged our data exchange providers to do and try to increase that is to continue to have staff that can go into Wisconsin Immunization Registry directly to address data quality issues that come up, setting up any interface over time as new vaccines come into the market and things. There will be possibility of errors that occur, and we continue to work with our providers to try to correct those errors, but a lot of times they may not have the staff available to take on that role. Getting into staffing, turnover is high, and Tina mentioned it, and I will echo it. Oftentimes, especially the small organizations, may only have one or two staff that have access to the registry for those doing direct entry, and even those data exchange providers only tend to have a couple staff with access. So when turnover occurs, the training necessary to get staff up to speed in a quick manner can be challenging. We are, as with Michigan, we are moving towards use of more video-based training. We historically have had training modules built into our immunization registry, but what we found out with COVID was that, and we provided the training for COVID through a video that they could read or watch, etc. And that seemed to be something that providers were very interested in seeing more of. So moving the training modules from outside of the immunization registry into websites or being available to them via email or other means. Getting into some of the entities that don't use the registry, I think Tina mentioned VA is one that we'd really like to bring on. We also, historically with WER, because we're not mandated, we came up with the means to sort of fill in the gaps of the information we had been, or the information that was immunization information in our state. So we received data from Medicaid, the claims data that helped us fill in some gaps. And we've always had strong support from providers to enter doses historically that may have been given at another location. But one thing we've seen with data exchange, as providers moved to data exchange and weren't entering information directly, we did run in situations where there are data exchange providers who do not want to either collect historical information in their electronic health records or submit that information to WER, and continuing to work with them to help us fill in those gaps that we do see in immunization records. And I think the other one, and again, Michigan and Minnesota have been great partners in this, in trying to fill in gaps is getting information for Wisconsin residents that are immunized out of state in either of those states and get that back into the immunization registry. So when they do see a provider within Wisconsin, they have a more complete record.
Yeah, I would echo that the partnership between Wisconsin and Michigan with regard to the data exchange has been extremely helpful with regard to the COVID vaccinations that occur across borders with each of our residents. It's been invaluable to have that data exchange in existence already before COVID hit. So that what we basically did is increase the frequency at which we exchange data. Instead of monthly, I believe we went to twice a month, which only improved both of our numbers with regard to vaccination rates, because then we could take into account the vaccinations that are occurred across borders.
Great, thank you both. And it looks like, I think there was a question that came through. I'm just kind of monitoring that chat. There was a question that did come through on that VA immunization record. So I'm really glad that both of you kind of spoke to that to be able to answer that question. So now we're sort of shifting, and I think both of you sort of have touched on some of these points, but if you can kind of speak to just sort of the recent things, you know, both of you sort of mentioned sort of a little bit about the forecasting capabilities and that importance of kind of making sure that that's available. And you talked a little bit about sort of the registry enhancements. I really want you to kind of speak to a little bit sort of, you know, Ben, sort of the successes. And I think one of the things that you both you, Tina and Matt, mentioned was kind of that ability, especially with COVID. You know, if you're able to get your vaccination across the state lines, you're able to share that information. And because you're able to do that more frequently of sharing that information, we just sort of had a more complete record for a patient. And so again, if Tina, you want to start on this one?
Sure. Well, the goal with any immunization registry is to provide to the medical community, to the providers, a correct forecasting of what that patient is due for. And that only comes with making sure that the immunization history is as complete as possible. And so especially, again, it came clear with COVID, the interstate data sharing really does need to be expanded upon. I know that I'm in conversations with Indiana, Ohio, and New York State in order to exchange information right now in order to get the COVID vaccination information for our residents that obtained those vaccinations in the other states into our registry. We're interested in exchanging with Florida as well, just because of the snowbirds that go down there for the winter and are there for 6 months and have had their COVID vaccinations down there. So I think with regard to our forecasting capability, I think there's going to be quite a bit of improvement with regard to interstate data sharing as a result of the pandemic. So that's a good thing. I think the other thing that has with regard to forecasting capabilities that I know our department is interested in is that some patients who have chronic healthcare conditions have a different forecast than a person without that condition. So in other words, a person with a heart, cardiovascular disease, kidney disease, diabetes, they have different forecast of when they are due for various immunizations and what type of immunizations. We're interested, our department is building a chronic disease registry capability. And so we're interested in how can the immunization registry leverage chronic condition information for a person in order to specialize the forecasting capabilities. So that's kind of future right now as we build that chronic disease registry on how we can leverage that information in order to improve the immunization forecasting capability based on the presence of a chronic condition. Of our successes, we've had for many, many years the ability to produce vaccination rate report cards by county in Michigan. Especially with the COVID pandemic and the lockdown, I'm sure Wisconsin has the same situation where a lot of our children are behind on their vaccinations, and those vaccination rate report cards demonstrate that clearly when we publish those on a monthly basis to our counties and our local health departments. As I said, HL7 has only allowed us to expand our ability to have adult information in our registry, which is invaluable. Probably the biggest success in the last year, in this last calendar year, is we hired some staff that really were quite talented in how to present data in an electronic format. And we published our first influenza dashboard that was available to the public to view influenza information. We leveraged, when COVID hit, we leveraged that influenza dashboard to create our COVID dashboard. And that has been highly successful. That COVID dashboard led to the development of a secure data sharing COVID dashboard. In other words, a dashboard that only local health departments or approved partners could log into in order to collect information from that site. So we call it a secure data sharing dashboard. We also, just in the last couple of weeks, created for our staff our own internal COVID dashboard that provides the ability for us to slice and dice information in order to really start honing in on things like race and ethnicity or poverty areas of the state, and try to use that information in order to do vaccination planning. Those have been huge successes and really are pointing the way for future development. But that's our most current successes. Matt, how about you?
Guess I'll start off talking about sort of the forecasting capabilities and kind of, I guess, getting more general with immunization registries. Most immunization registries do an excellent job at forecasting for individuals in the system or for future vaccines. I'm certain Michigan, like Wisconsin, interacts with the American Immunization Registry Association, and they have teams that work with us and provide us information on how to take the ACIP schedule, immunization schedule, and convert that into an electronic means for forecasting. But we also have a lot of interaction between states. In Wisconsin, Wisconsin's Immunization Registry is being used by a number of other states as a basis for their own. So we do have work groups with those states that allow us to continually work to improve our forecasting and make sure that we are extremely accurate with that. As far as some of the successes that we've had in our state, and some of these are more recent, but some of them are more timely. We have consumer access in Wisconsin, so individuals can go in and view their record or their dependents' record through the immunization registry. And there's a PDF record with sort of an official copy that they can print off through the registry. We've, like Michigan, saw the value in implementing data quality reports and report cards for providers and local health departments, as well as reports that our staff use to monitor the system. We can run queries against the incoming HL7 data, the real-time data coming in, and quickly assess issues and address those issues in a timely manner to prevent large problems with the system. Some of the recent changes or recent things we've seen is we're currently working with the schools within Wisconsin and linking to their student information systems. for them to pull information on students. Currently, right now, schools would have to log in through our user interface and get that information, but our efforts should improve the school processes as far as getting that information. And they do have the ability to provide information to the immunization registry if they have a FERPA release that would allow them to do so. But probably the biggest change we made in the last year, and it went in about this time last year, was one of the challenges that you have with a mature immunization registry is something that's been coined as population inflation. Individuals get put into the immunization registry, but after they move outside of the state, we are not aware that they've left the state, and we continue to keep them in the registry. Wisconsin has, I believe, just under 10 million individuals within the immunization registry, but a state population of about 6 million. So we implemented some client status functionality, and which one of the things was to create what we call a dormant state for individuals. And it's based on the time that the last individual was seen by a provider, but also the last time a provider queried for that individual. So if they were trying to assess that individual. And it's fairly conservative as far as the timeframes. But the individual will go into that dormant state, and then providers who want to use our reporting features and more would not have those individuals come up in their reports because the system believes those individuals are not currently in the state. And again, it's on the conservative end. If anybody does query for that individual, they immediately go back into active status in the registry and are able to be viewed and pulled up in reports. And we've been able to, I believe, of the 10 million clients we have in WER, after we implemented the dormant state, I believe we are down to about 7.5 million clients. So we were able to knock that down a fair amount. And again, these are individuals we believe have left the state over the last 20 years of our existence and are no longer in Wisconsin. As far as future enhancements to the registry, we are in kind of an odd place right now, just finishing up on COVID-specific functionality and starting to look towards what life might look like in the future post-COVID. And it's going to take a while before we get out of that, out of our COVID activities, but development has to be planned far in the future. So we're currently in that process. We did identify a couple things that we want to work on. We'll be making some improvements in our provider setup within WERP and also how we track provider type, which will increase our reporting options on an organization level. So situations where we have large health systems that in the past linked to us directly, and we had an association to those large systems, and they were able to run reports on a system-wide basis. When they moved to submitting data through a hub, essentially an entity that's just intended to pass data, we lost visibility and lost the ability to report on those large systems. And we're going to be putting in functionality to allow us to address that. And then also looking, that should help us understand the sources, the change in type, and understand the sources of incoming data and help us better determine on where our gaps are. And then the final thing, and this came up with COVID, is we have a lot of providers that do want to receive data and put it into their systems for analysis and outreach. And we're continuing to look to ways to provide that data to providers, either through batch means or the possibility of a push of data in the future.
Great, thank you both. So I know we are coming up on about 10 minutes left, and we wanted to leave a little bit of time to kind of open it up for questions and answers. So I think, you know, you sort of both have sort of touched on a little bit more sort of that COVID lens. But again, as you both sort of alluded to, immunizations just sort of don't stop. They keep going, and sort of, with pneumococcal, there isn't sort of a season like there is for influenza. So can you just like really briefly kind of just touch on sort of what you have, if you have anything sort of planned for, how do you sort of promote the, ensuring sort of individuals are receiving that pneumococcal, and then sort of as we sort of ramp up for the fall and the influenza efforts that would be happening as well. And Tina, if you want to start on this one.
Well, with regard to the influenza season to come, we're already planning for how we can work with our employer organizations in order to address employee health and be a better partner with regard to our corporate business partners in ensuring that vaccination clinics are offered. And especially since COVID can be co-administered now, we look forward to the ability to not just have an influenza clinic and expand our influenza clinics, not just with our schools and our other local health department efforts, but more address business areas. The pandemic has obviously shown how an impact on businesses can be a negative impact overall. And so the plan is to work with our economic development unit in order to identify large employee organizations that would like to work with us with regard to better immunization efforts with regard to influenza, and then hopefully address anybody that still has not had COVID vaccinations going forward. I've said several times today that the adult data has been expanded upon since 2012 just because of HL7 reporting. And so it provides us another opportunity on how we can address the adult vaccination statuses in the state. Because we were only childhood mandated reporting, our childhood data is excellent. Our adult data has been improving greatly. It has improved even more with regard to COVID vaccinations. We've added over 300,000 new adult records into the immunization registry, which provides the opportunity to then look at working with the providers to encourage that the adult vaccination information is entered into the registry as well. The introduction of adult data and improving on adult forecasting, though, does depend on data quality improvements that need to be made. We have plans to work with our Secretary of State, which is our DMV office, in order to receive address and name changes that they receive on a regular basis when people change their licenses, in order to improve the quality of the data in our immunization registry, so that adult data, because they don't get vaccinations as frequently as children, that adult data can become stale. And so we're working with our Secretary of State to get address and name changes. We also have been in conversation with our Vital Records office. We've had an absolutely successful project with our Vital Records office to automate the receipt of death data. We've always had an automated process to receive birth data as soon as the certified birth is received. But we now have the ability to close a record through an automated process that we receive the certified death within 3 days of death, so we can close out a record as well. But the Vital Records Office also maintains marriage and divorce information. And so to improve the quality of adult information in our system, we want to work both with our Secretary of State and with our Vital Records area to improve the data quality of adult information in the system, which then only allows us to more accurately work with the provider community as it relates to the adult immunizations.
Okay. I guess from Wisconsin standpoint, I'll start off in speaking a little more generally about sort of the pneumococcal and influenza efforts. I think one of the things from the registry standpoint, we've been pushing to get more and more providers on because that information is needed in order to make correct assessments by our providers. So in general, working to get that information in to the system by getting more providers on and providing a more complete picture. Getting into pneumococcal specifically, the initial schedule that came out and its ties to pneumopoly, PCV13 and pneumopoly, it was a very challenging schedule, but we were able to get that in and make that forecast or recommendations available to providers. Part of that sort of that effort is getting providers to view that recommendation either through the user interface, but data exchange as well. You do see differences in data exchange providers on whether or not they use the recommendations from the Immunization Registry and pull those into their electronic health records. And we've worked hard to get our providers to use that, so they have improved recommendations in those efforts and are getting people immunized appropriately. With influenza, what we've done with influenza in the last few years, during the H1N1 outbreak of 2009, 2010, we built a mass vaccination entry option, and we actually use that for COVID today. But between those two outbreaks, we made that available for influenza providers. So employee health and long-term care and the mass immunizers that may not have electronic systems send data and also had staffing issues. The mass vaccination entry option was a very quick means of getting an influenza dose into or accurately and just bouncing between a couple screens. So we've seen an increase in the amount of influenza data coming over the years for multiple reasons, but the mass vaccination feature has been one of those reasons. I think, I guess, sort of pivoting to COVID and sort of what had helped out or had done as far as our COVID efforts. As I mentioned, the mass vaccination tool has been used heavily, but we have also been pulling data from by our jurisdiction, our city and county health departments, and making it available to them outside of WER for access, so they can more easily look for pockets of need and work to get maybe a mobile site into that area and get people properly immunized for COVID. And then we've also seen a large increase in the use of data from WER for putting on our website and making available to the general public so they can keep track of our efforts and feel more informed and involved in what's going on.
Great, thank you both. So we have about 2 minutes left. So I would just, we had one question come through. It was really speaking, Tina, to you when you mentioned sort of having that ability for your consumers to be able to open up their, and access their immunization history. Do you happen to have a launch date or an anticipated sort of timeline of when that would be available, or is that still sort of in discussion?
That's an excellent question. Our current projected date is the first week of August. We are finishing up our business requirements right now. So the department, this is a high priority in our department. And so they are really pushing us to go live as quickly as possible. But the current projected date is the first week of August. Okay, great. Thank you. So I know we only have about a minute left, but if folks are able to stay on the line, we could go over maybe a few minutes. So if you have any questions that you want to ask directly, just remember, if you want to hit *6 on your phone, you can do that, or
find your kind of the unmute on your screen. Otherwise, I think those were all of the questions we had within our chat box.
Yes, that's correct, Jill.
Okay, thanks, Tony.
Yeah.
All right, so coming up on the hour, I know this was a lot of information, and I'm hoping that everyone found this very helpful. I was feverishly taking notes as well, so I thought it was a great presentation, and I just, again, wanted to extend my thank you to Tina and Matt. I know that you both have continued to have busy schedules, even as sort of COVID has sort of lulled slightly. So I really appreciate you being able to take the time today and be on the call with us.
We appreciate the invitation and the opportunity to share information.
Yeah, definitely. Thank you so much.
Great, thank you both. And for the remainder on the call, this is really just a reminder, we have an organizational assessment that we have requested our participants to complete. We have two different organizational assessments. One is focused on a nursing home and one is sort of looking at from a community lens. So if you have any questions, please feel free to reach out to us either at the info@superiorhealthqa.org, or as I mentioned, you can reach out directly to myself, Bill Hansen, or Tony Kettner. And with that, I just want to thank everyone for being on the call today. And again, thank you, Tina and Matt. And I hope you all have a wonderful rest of your day.